The ETSU Department of Psychiatry Grand Rounds. Today we welcome Dr. Reagan Gilley. Dr. Gilley is a current third year in the Department of Psychiatry. He completed his undergraduate training in biology, history, and chemistry at Western Kentucky University and attended medical school at University of Louisville in Louisville. And today his topic is sleep. Welcome.
All right. Well, good morning, everyone. If you can hear me, let's see if we can get this pulled up. Okay, there we go. All right. Forgive me as we start. My voice is a little raspy from allergies. But like Dr. White said, my name is Reagan Gilley. I'm one of the third-year residents here. Really excited to be here this morning. Very excited everyone was able to make it here. My topic today is on the relationship between sleep and neurodegeneration, including in that psychopathology, as well as cognitive decline. Getting started, just as a note of disclosure, I was provided a funded trip to St. Louis last fall by Neuron Pharmaceuticals to an investigators meeting along with Dr. Moore, looking at a possibility of getting a phase 2 drug trial here. It doesn't look like that's going to happen, but while I was there, was also able to attend a one-day symposium at the University of St. Louis on the topic of sleep and neurodegeneration. Its focus is more on the relationship between sleep and Alzheimer's, which is something we'll touch on, but served as a good kind of jumping off point for today's talk. So in sort of starting with that, just some initial thoughts with sleep. It's certainly something we all do. We all have our own relationships with sleep. Some sleep a little more, some sleep a little less. The old adage of the recommendation of 8 hours a night, which again is something we'll touch on here a bit later, leads to a lot of time spent in sleep. Third of life, so for someone who's 75, that's 25 years. That's around 219,000 hours. So it's a lot of time. But knowing there's going to be some variation with lifestyle, positions, and particularly I think with this group with healthcare providers. Doctors also being somewhat notorious for not having good sleep. Brought to a good point by this diagram showing sleeping positions of physicians, with the doctor often being absent from the bed. And as I think most people notice from their time spent in the hospital, sleep tends to happen in different places, in different positions, kind of whenever it can happen. I think for most people who've been on call, working night float, those sorts of things, sleep does tend to happen. So kind of bringing about a point for the pictures there, that sleep is ultimately this culmination of long-standing behaviors, or sleep hygiene, things that happen, that develop over the course of our education, our training, say, in residency, for instance, and how we live and work. And ultimately, as we'll see, these behaviors have long-standing consequences for our psychiatric health and our cognitive well-being. Getting started, just a moment on the history of sleep. So we've been sleeping for as long as we've been human. It's been written about as far back as the ancient Greeks, Aristotle. There's been some research done in the interim in the 1700s in France on biological clocks and circadian rhythms. But most sleep didn't really come about until the advent of electroencephalogram, the EEG. Though when the EEG was initially developed, Hans Berger in the 20s really just wrote sleep off as sort of this idling state. So the advent of modern sleep medicine really didn't come about until the 1930s with Alfred Lumie, who published a paper in 1937 talking about that there are indeed differences on EEG between awake and asleep individuals. This was researched further. In 1950s, William C. Dimmitt, a psychiatrist, sleep researcher, one of the founding figures of American sleep medicine, published a paper on his discovery of rapid eye movement sleep. This was followed up later in the 60s by Dr. Alan Richthofen, who was one of a group who helped do the classic sleep staging, the 4 stages of non-REM sleep plus the stage of rapid eye movement, which is something we'll talk about shortly. And then more recently, in 2007, there was a revision that combined the two parts, the deeper parts of non-REM sleep into one stage, and that of slow wave sleep, which again is something we'll touch on in a minute. But kind of first talking about why sleep in general. We spend a lot of time in sleep. Is there any real reason, or what do we really know about for why we spend so much time doing this activity? What has been denoted in the literature is that sleep is indeed essential. Researching with animals, all animals do sleep, even though there's no general consensus on why we sleep. It is indeed universal. It is tightly regulated. We cannot go without sleep without serious negative consequences occurring. Now, thinking about some of the functions of sleep, while there's no single consensus on why we sleep, there have been research into a number of other functions, including this memory, restorative processes to the body, as well as preservative processes to the body. Kind of jumping into that in terms of memory, particularly with consolidation of new memories and reconsolidation of existing memories, and that of the enhancement of those memories, connecting it to other memories, occur in sleep, though it is dependent on what type of memory. There are two groups of long-term memories, that of declarative memories, including episodic or experiential memories, as well as semantic, dealing with specific facts. And these are most affected during slow-wave sleep, as compared to non-declarative memories, which are those of implicit, unconscious memories, instrumental, or generally doing things like classical conditioning, procedural-type memories. These make up non-declarative memories, and these are most effective during rapid eye movement sleep. So transitioning then from memory to restorative functions for the body, there are a number of immune and endocrine functions that occur during sleep, particularly with cortisol and thyroid-stimulating hormone that occur in slow-wave sleep. We also know from animal studies and in the rare cases of things such as human familial fatal insomnia, cortisol levels go higher when we go without sleep. Ultimately, there are changes with the immune system, and people ultimately perish from their insomnia. So we know then that sleep has a number of critical restorative properties as well to the body, as well as a pretty important thing that we'll come back to later as well, this notion of preservation or housekeeping for the CNS, that when we sleep, there is increased removal of neurotoxic metabolites, including things such as amyloid beta. So in sort of summing up that sleep is indeed essential, there's this quote by Dr. Richthofen, which I thought was kind of a fair point. We sleep for a number of functions, and we'll see that without that sleep, it does impact our cognition, it does impact our psychiatric well-being. But to look briefly at the underlying biology of sleep, we all have a biological clock. This is known as our circadian rhythm. In humans, it's just a little bit over 24 hours. There is some variability, so it can be reset or re-entrained to anywhere from about 23 and a half hours upwards to 24.65 hours fairly easily. As a side note, the 24.65 hours has been used by NASA for training astronauts for deep space missions, as it's right close to a Martian day. And there have been other studies, though a bit back, showing that outside of any sort of environmental cues, we have the ability over a period of time of about a month to set the circadian rhythm to a period of about 28 hours. Though one of the biggest things, as we'll see, is that of light as a modulator for our circadian rhythm. And part of that deals with the underlying anatomy. Our circadian rhythm comes from the suprachiasmatic nucleus. It's the small area in the body, as we'll see here in the video. It's at the area of essentially the optic chiasm and the hypothalamus. And as we see, it's in part modulated through light, but through other neurotransmitters as well, serotonin, norepinephrine, dopamine, just to name a few. But it's this small area right here, consisting of about 20,000 neurons that control our biological clock. And just as a side note, 20,000 out of new estimates of about 86 billion neurons in the whole brain. So we're talking about a very small group of neurons that are doing the controlling for the circadian rhythm. If we look and transition to genetics for a moment of the suprachiasmatic nucleus, there are several major genes and some single nucleotide polymorphisms that have been implicated for both sleep and psychiatric disease. The clock genes are that of the circadian locomotor output cycles, kaput, have been implicated for major depression as well as insomnia. And the PER genes, which are the period circadian clock genes, have been implicated in things such as addiction and bipolar disorder. To focus a minute on PER2 and bipolar, if we think about bipolar from a sleep perspective, it's really one of the most interesting processes. We have periods of mania, where we have episodes with decreased need for sleep. And then on the other end of the pole, in bipolar depression, we have periods of hypersomnia and we have periods of insomnia. And thinking back to light as a modulation and sleep as well, we know from research that lack of sleep can either improve mood for those who are bipolar depressed or can induce mania, and depending on where the person is at. Light therapy has been shown to induce mania as well as improve mood in bipolar depressed patients. And I think most interestingly, this notion of dark therapy, which are distinct periods of time without any sort of an environmental light that have been used to help rapid cyclers stabilize. So if we may for a minute shift from sort of the anatomy to a note on the physiology of sleep. There are two major systems of neurotransmitters, the cholinergic system and the monoaminergic system, that are responsible for wakefulness, as well as coordination of rapid eye movement sleep with the cholinergic system, and the monoaminergic system for non-rapid eye movement sleep. To break these neurotransmitter systems down to some of the more prominent, we see a list here. The largest and most prominent of the sleep-promoting neurotransmitters is that of GABA. Now, for the arousal-promoting, there are a host, including some common neurotransmitters that we often think about, norepinephrine, serotonin, histamine, as well as this one at the bottom, orexin. Orexin is also known as hypocretin. It is something that has only been, or was discovered about 1998, so it's not been around for too long. It's the target of some new hypnotic drugs, or hypnotic drug as well, and it's also been directly implicated in patients with traumatic brain injury. So it's something we'll return back to in just a minute. But looking at these neurotransmitter systems in action, we see here on the left the arousal-promoting areas from the brainstem, reticular activating system, project up through to areas of the cortex during periods of arousal and pro-wake. And then in periods of sleep promotion, they are inhibited, they are turned off by GABA. And when we enter into sleep, we have discrete stages of sleep, what we were talking a little bit about before. We start with the awake stage, as we see on the right. EEG is quite active, including things like beta waves. There's eye movement. On the EOG, the electrooculogram. The EMG, the electromyogram, also shows a good amount of muscle tone. After awake, we transition to stage 1 sleep. The EEG is a little less active. We transition to a period of predominantly alpha, alpha waves. This is also a period of time where hypnagogic hallucinations occur. We spend about 5% of our overall time asleep in stage 1. This does increase a bit with age. From stage 1, we transition to stage 2. So this is non-rapid eye movement, stage 2. We, again, slow down a bit more with our EEG. It's predominated by theta waves, as well as these occasional sleep spindles, as we see on the graph. Eye movement slows down a bit as well, and muscle tone is generally a bit reduced here, too. We spend about 45 to 55% of our overall time asleep in this stage. So transitioning from stage 2, we enter this period of slow wave sleep. That is the new combined non-rapid eye movement, stage 3. And here we see the EEG waves have slowed down fairly significantly as well. It's predominated by delta waves. It's very little muscle tone. And we spend about 15 to 25% of our overall time in this stage of sleep. This is also where a number of the restorative functions, memory functions that we were just talking about occur. As well, I think quite interesting as when a lot of when the time that parasomnias occur. Things such as night terrors, enuresis, sleepwalking, somnambulism, sleep talking, somniloquy. And shifting then after this period of slow wave sleep, we then go to this period of rapid eye movement. It's noted for, of course, rapid eye movement on the electrooculogram. We still have no muscle tone generally at this point, and the EEG has increased pretty substantially. It's denoted here by beta and generally theta waves. And we spend about 20 to 25% of our overall sleep in rapid eye movement. And this is also the period of time where we generally have, or is generally associated with, very vivid dreaming. So to transition then from the functions of sleep, the underlying anatomy and physiology of sleep, to talk about some common conditions that affect sleep. And I think one of the most common that we run into is that of obstructive sleep apnea. Now, obstructive sleep apnea occurs in over 25 million American adults. It's quite common. And as we will see, when we have untreated obstructive sleep apnea, it leads to affective symptoms, particularly depression and anxiety, as well as cognitive impairment. And as we'll see too, that these are mediated by neurodegenerative changes. So to look for a moment between obstructive sleep apnea, depression, and anxiety, it depends on who you look at in the literature. This large review article reviewing over 50 articles found a pretty wide variability in terms of depression and anxiety, anywhere from 7 to 63% for depression, 11 to 70% for anxiety. But nonetheless, a sizable percentage of patients having both depression and anxiety. Interestingly as well, they found a variable response rate to patients with CPAP, continuous positive airway pressure treatment, though in their notes did say that most of the studies were very short term, under 3 months. Though there were a few that went as far out as about 2 years that also showed conflicting results. Some showed improvement over that period of time, others did not show any. As well, if we look at just the relationship from another study, a 2012 study of over 9,700 people, it found, at least in regards to development of depression, an increased odds ratio of about 2.4 for men developing major depression. And for women, quite interesting, it was as high as 5.2 times, or 5.2 increase for risk for development for major depression. So shifting then from depression, anxiety, affective symptoms to cognitive symptoms, there's also a really interesting study that came out fairly recently in 2014. It took 17 patients who had recently been diagnosed or newly diagnosed with obstructive sleep apnea, provided them with treatment with CPAP, did neurocognitive testing at baseline, at 3 months, at 12 months, and then as well as imaging to monitor for white matter tract abnormalities, and compared this with a group of 15 controls. What they found at baseline in terms of their cognitive assessment was that the control group outperformed those with obstructive sleep apnea. I think quite interesting as well, the imaging found that there were a number of white matter tract abnormalities, particularly affecting areas of the right parietal lobe and the right superior frontal gyrus. So this is at baseline. 3 months later, however, the obstructive sleep apnea group had a statistically significant increase compared to baseline for their cognitive scoring. And this was correlative as well with fewer white matter tract abnormalities on imaging. The authors hypothesized this is likely due to a resolved intermittent hypoxia that occurs with obstructive sleep apnea. They're now able to get continuous positive airway pressure, so they're no longer having obstructive episodes, and so the white matter tracts are able to resolve. So this is at 3 months. I think most interesting is at 12 months of follow-up in the study, there was no statistically significant change in terms of cognitive assessment, cognitive abilities at 12 months when compared to the group, the obstructive sleep apnea group at 3 months. So not a functional change, but looking at the structural changes on repeat imaging, we see again resolving white matter tract abnormalities. So it's this kind of interesting relationship between structural changes not leading to functional changes, at least at the 12-month point. And I think for most anyone who deals with patients with obstructive sleep apnea, one of the biggest issues is that of compliance. Now, depending, again, on who you read in the literature, there is between a 40 and 50% compliance rate at a time period of 3 months. So that means we've got 5 to 6 out of 10 people who are not getting this treatment at a period of 3 months, meaning they're going to be at much higher risk for developing depression, anxiety, as well as these cognitive concerns we were just talking about. Now, the problems and reasons cited for discontinuation are many. These are some of the most frequent ones. And so this has led, at least in the past few years, to development of different types of masks, different styles of masks, different advertisements for masks, his and her mask, to try to get people to use their mask, as well as development of some other oral devices, including this dental device that helps relieve obstructed airway, as well as a tongue guard we see here. However, in terms of effectiveness, they're generally regarded as second-line treatments. They don't work as well as our CPAP, and they're generally recommended for mild to moderate obstructive sleep apnea. So those are the things that are on the markets currently. There are also some really interesting things that appear to be coming down the line. One is this device that's called a micro CPAP. This company came across online called Airing, received over $1 million in terms of crowdfunding recently, developing this device that just sits in the nostrils and provides continuous positive airway pressure through the night. They are hoping, at least according to their website, as of a couple weeks ago, to try to get FDA approval for the market in 2018. So it's something to maybe keep our eye on that could help increase compliance, possibly, as well as another device, which is an implantable device, a hypoglossal nerve stimulator. This device is implanted, as we see here. It monitors respirations. When it detects an apneic episode, it sends an electrical charge through the hypoglossal nerve, causing contraction of the musculature and relieving the obstruction. There have been studies with this that have shown a reduction in the hypoapnea-apnea index of over 50%. So it does appear to at least to be effective. Though still currently, there's still a good deal of research going on with this. So there are a couple of interesting options coming down the line for obstructive sleep apnea. To shift then from obstructive sleep apnea to another common process that we see, particularly with our veteran patients, that of traumatic brain injury. Now, for people who have cared for patients with TBI, there's, again, some variability in the literature, but there's a sizable percentage of patients who have problems with their sleep-wake disturbances. Interestingly, as well, in a paper that just came out this year, sleep has been shown, at least in this case, to be a prognostic factor in outcome for severe TBI. Severe TBIs, in this case, being categorized by Glasgow Coma Scales of less than 8 on admission. And what they found was that patients who had lack of sleep elements ultimately had longer hospital stays and poor dispositions at time of discharge when compared to those who had intact sleep architecture. They stayed about a week less and had a much better disposition at time of discharge. Now, as we alluded to earlier, the neurotransmitter orexin, also known as hypocretin, has been implicated in traumatic brain injury, as we'll look at in the next couple of slides. It comes from the perifunicular area of the lateral hypothalamus, again, a very small area of about 70,000 neurons, and has been shown to be critical to the maintenance of arousal, of wakefulness, and also to help in coordination with rapid eye movement sleep. So we might see then this link if orexin gets disrupted in TBI, why we might have some of these issues with the sleep-wake cycle. As a quick side note, it has two names, orexin and hypocretin, from two different groups who discovered it at around the same time in 1998. These names are both continuing to be used and are interchangeable. So looking then at some studies in humans, there's a small study of 4 patients who had passed from severe TBI, matched with 4 controls who had died of other causes. What they found was a statistically significant difference at time of autopsy of the number of orexin or hypocretin secreting neurons versus that of the controls. So this is in a small group of patients who passed away from their TBI. In patients who survived their TBI, there was another really interesting study that looked at CSF, cerebrospinal fluid levels, of orexin 4 days after TBI. And what they found in the acute phase was a quite reduced level of orexin, the general cutoff being under 320. On average, they found it to be 79. At the time of follow-up, 6 months later, it had increased and resolved, with the average level being around 406 PGs per ml. And this is also found to be statistically significant in both cases. So this leads to the question: we have we have a general idea now of what is implicated, what may cause some of these sleep-wake disturbances. Do we have any good effective treatments right now? From my review of the literature, there's no currently accepted methods. There's a lot of research going on to look about ways to help, and I think one of the most interesting is actually supplementation with branched-chain amino acids. So everyone thinking back to your biochemistry, I'm sure will easily recall, their branched-chain amino acids are leucine, isoleucine, and valine. And that these have been shown, again, the data on this is fairly limited, to be directly reduced as well after traumatic brain injury. So what we see then is, in, again, small study, an Italian study of 20 patients with TBI matched to 20 controls. The patients all admitted to an acute rehab. The TBI patients were supplemented with a fairly large amount, about 20 grams of branched-chain amino acids a day. And what they found was that 15 days after rehab, or in the rehab process, there was a statistically significant cognitive improvement from time of baseline and also in match to that of the control group. So this is a treatment option that there's still a lot of research ongoing, but certainly from some of the limited data, it does appear to be a bit promising in things that may be helpful. So transitioning then from traumatic brain injury, I think something most people think about, that of the aging process when we talk about sleep and neurodegeneration. As we know, when we get older, sleep quality gets reduced. We're awake more often, we get less deep sleep, we get less rapid eye movement sleep. And when we look at it in a schematic way, with the young adult being at the top in terms of stages, older adult below that, and then 20, 45, and 70-year-olds down at the bottom. A couple things to point out. We have a pretty large reduction in the amount of slow-wave sleep, as we see over the course of our lifetime. Mirrored to that is a decline in the amount of rapid eye movement sleep, though not anywhere near as much. As well, the amount of time that we spend awake and in slow-wave sleep also increases as we age. Now, thinking in terms of patients with significant neurocognitive disorders, such as Alzheimer's, for those who may know someone with advanced Alzheimer's disease or have treated patients this way, we know that the sleep cycle also gets more fragmented. There's issues with sundowning, fatigue, small sleeping periods through the day and through the night. That sleep essentially, again, becomes more fragmented with advancing periods of neurocognitive disease. So the question I would pose, though, and something we'll look into, is we know that cognitive decline, as we were just talking about, leads to changes with sleep. Can sleep changes lead to cognitive decline? Could we be looking at a chicken and egg sort of scenario? Now, one of the best markers of sleep is this notion of sleep efficiency. It is essentially the total amount of time in each of the stages of sleep divided by the total amount of time we spend in bed. Multiply that by 100, you get a percentage, and it's overall sense of how well the person sleeps at night. And the general idea is to be above 70% with that, as we'll soon see. Now, looking at some studies that have looked at sleep in non-demented elders, this study from 2013 of over 700 older men and women, average age was around 81, found that sleep fragmentation, and that is decreased sleep efficiency, was associated with a 1.5 times increase for neurocognitive decline when they were, and through the study they were administered a battery of about 19 cognitive tests. Now this was over a period of 3 to 6 years, and also controlling for some confounding variables. In terms of larger studies, there's been a larger study with women, almost 2,500 women, right at close to age 69. The testing was a little more limited. It was TRELS-B as a marker of executive function and a modified mini-mental status as an assessment of global function. But the interesting thing with this study, follow-up was over the course of 15 years. And mirroring what we were talking about before, poor sleep quality does lead to an increased risk of cognitive decline when we're controlling for confounding variables. Particularly with the sleep, that notion of sleep efficiency that we were talking about. Under 70% in this case led to an odds ratio of about 1.7 times more likely to have problems in cognitive decline. Initial latency being greater than or equal to an hour also led to a higher risk of cognitive decline, as well as the total amount of WASO, or wake after sleep onset, the more that a patient is awake through the night, led to an increased risk of cognitive decline. So this is in a group of women. Looking at a similar study, but looking at men. These were cognitively intact, community living men, average age of about 76, and the general follow-up was about 3.5 years. What they found, again, kind of on this same theme, poor sleep quality, poor sleep efficiency led to increased risk. In this case, when they were specifically looking at the data of both executive function decline as well as global cognitive decline. With, again, looking at some of the odds ratios from the study, sleep efficiency under 70% led to about a 1.5 times risk of, in this case, executive function decline. And that the number of longer periods, that being greater than 5 minutes, that they were awake overnight, if that number was equal or greater than 8, it led to about a 1.4 times risk of decline in both global and executive functioning. So these past studies have been looking at non-demented elder populations. There have been really limited studies of looking at middle age, but one of the biggest is this study called the Whitehall 2 study. It was a group of about 1,500 women and about 4,000 men, ages 45 to 69 at start. They did a neurocognitive assessment at baseline as well as at follow-up. And the follow-up was variable, 4 to 7 years, with an average follow-up, again, of about 5.5 years. And what they found was quite interesting. For women, at both baseline and at follow-up, those who scored the highest on cognitive assessments were those who got between 6 to 7 hours of sleep at night. Now, for men, it's similar, but a bit different. 6 to 8 hours yielded the highest scores at both baseline and follow-up. Now, what was quite interesting as well, I think the most interesting thing from the study, is that those who over that course of about 5.5 years went from that middle of the road 6 to 8 hours to either the short end under about 5 hours or the long end over 9 hours, experienced what the author has termed accelerated cognitive aging. And that those who went from the middle part to either end of the spectrum generally experienced about a 3 to 8 year increase in their cognitive aging at time of follow-up. The authors hypothesized that those who slept longer, over 9 hours, were actually people who had generally poor sleep efficiency as well, difficulty maintaining their sleep, so that led to them sleeping longer, though they did not do a sleep study on any of these patients to know that, but that's just what they were hypothesizing. But the question becomes, what could a possible mechanism be to account for these people who sleep less having worse cognitive outcomes? As we mentioned before, that notion of CNS preservation, of housekeeping, comes back. Those who sleep less, as we see here, particularly under 6 hours, have a much higher amyloid beta burden than those who sleep longer. And a mechanism for this has been proposed by Lim and others in 2014, still being researched, but it sort of speaks well as to a possible mechanism for this. That essentially the longer that we're awake, the more active our neurons are. The more active our neurons are, the more amyloid beta and tau proteins that are made. That leads to increased deposition and increased burden of amyloid beta, tau, and ultimately leads to, through mechanisms of either neurometabolic or immune dysfunction and dysregulation, increased sleep fragmentation, which means we're awake more, which means we make more amyloid beta, and the process feeds itself and becomes this vicious cycle that ultimately leads and feeds into cognitive decline. So transitioning then from talking about the aging process to that of sleep and psychiatric illness. Now, for people who have primary insomnia, several studies have shown that there's a higher risk for people with depression, about a 10-fold increase, and about a 17-fold increase for those people to develop anxiety when controlling for confounding variables. There has been some research recently as well into looking at the findings on sleep studies for patients with specific psychiatric illness, and one of the most well-researched is that of major depression. And there are generally very consistent findings for people with major depression and sleep. Taking longer to fall asleep, increased time awake after they fall asleep, and the total amount of slow wave sleep being decreased. And this is for non-rapid eye movement sleep. For people with major depression, their rapid eye movement sleep actually increases overall. The individual episodes are longer, it's a greater percent overall, and the amount of time it takes to get into REM is actually decreased. And both of these will be pretty important in just a minute when we talk about some of the common treatments that we use for our psychiatric illness. Now, shifting though from major depression to something else that I think is really, really interesting, and that is sleep as an independent risk factor for suicide. There was this really interesting paper published over 100 years ago in The Lancet that proposed a possible relationship between those who were sleeping poorly, those who had insomnia ongoing, and those who completed suicide. More recently, the data is a bit conflicting, and there's not a ton, but it does show at least some association. A study of about 1,000 people in 1990 showed that increased insomnia symptoms did yield an increased risk of completed suicide at follow-up within about 13 months. Another study in 1997, a much smaller study, about 100 patients, found that those with hypersomnia and insomnia had higher risk of developing suicidal thoughts, though there was no evidence on completed suicide rates for this study. As well, I think quite interesting, a large study out of Japan in 2005 found that difficulty with maintaining sleep, that of middle insomnia, yielded an increased risk of completed suicide at follow-up 14 years later. Though, as I did mention, there is some conflicting data excuse me, in the literature. A study in 2005, again, smaller study, but noted when controlling for all the variables that they remarked that it was actually the presence of nightmares, recurrent nightmares, that led to an increased suicide risk and not that of insomnia. So in shifting then to, and kind of finishing on this note of the effects of some of the medications we commonly prescribe and their effects on sleep. When we look at groups of medicines, including that of the tricyclics, the SSRIs, the SNRIs, we find that they actually suppress REM. So we get less REM overall on these, less REM sleep overall on these medicines, as well as taking a longer amount of time to get into REM. And as we were talking about just a minute ago, this does help reverse some of the findings that we find with major depression, as well as some of the common hypnotics we use. Trazodone, mirtazapine, of course, help us fall asleep sooner, but they also increase that amount of slow wave sleep, that particularly restorative part of sleep that is decreased overall in patients with major depression. And I think interestingly as well, bupropion, just as a side note, has been one of the medicines shown to actually increase the amount overall of rapid eye movement sleep. So in closing, kind of summing up with everything, a couple take-home points. One, and if nothing else, sleep is not wasted time. There are a number of functions that sleep is important for, and there are negative consequences if we don't get it. As well, that the overall biology of sleep and its interplay with neurodegenerative cognitive changes, as well as psychiatric illness and the treatments like we were just talking about, all interface with each other in sleep. And I think most importantly as well, that these neuropsychiatric changes, the affective changes, the cognitive changes, through things that we've talked about, obstructive sleep apnea, traumatic brain injury, dementia, major depression, perhaps even suicide, may in some form be modifiable through targeting sleep. So if nothing else, would certainly want to say sleep more because it's good for you, but maybe not over 9 hours. And would also like to finish up by just saying I really appreciate everyone being here this morning. Appreciate those who may have taken this message to heart and are getting a little sleep right now. And also for those who aren't. And wanted to also thank Dr. Moore, I don't believe was able to be here this morning, but for his mentorship in this project. As well, we've got certainly some time left, so wanted to make sure we had enough time to hear any questions or concerns, comments, observations. And otherwise, I'll open up to the floor. Thank you.
First of all, I'd just like to thank you for a really very understandable presentation on a wide number of conditions. I think it was very well done. I really liked your slides, very simplified so that we can all get the core facts. A couple of questions I had to do with, one of the couple of the slides you presented talked about sleep efficiency when it's diminished, and the difference between men and women. And one of the things I would suggest is that perhaps part of the reasoning that men appear to have problems earlier, and certainly the age that they studied was younger, and they may not be living even as long, perhaps might be the protective factors that estrogen offers earlier on, because we know that in menopause, sleep disturbances become pretty significant. And so that may be part of what's perhaps deferring later in terms of sleep changes. The other thing I was wondering about was, did you come across any studies, and you talked about sleep apnea, about upper airway resistance syndrome, which seems to be more common, and you may see that even in young people, or people that may not be as much overweight, and often involves some of those NG tubes that they put in to actually get the subtle pressure changes, as to how that type of prevalence is there, and how that which sleep disturbances in the non-typical populations that we expected in might in fact be affecting a lot of the, perhaps some of the psychopathology that we're seeing.
Absolutely. I did not come across anything on it, but I think that's a really, really fantastic point to consider. And certainly some of the studies have been fairly limited, and we're focusing kind of on I think, an older population, but I think poses a really good point and something that maybe should be looked into.
If not, I have one more.
Sure.
You talked about the association of nightmares, perhaps, that might be actually more country. And I would venture to say that nightmares often are a reflection of some of the anxiety patients are experiencing, and it may be there is data that talks about anxiety that actually increases the risk for suicide. So that may be the association there.
Absolutely. With that study, it was particularly they were controlling for, I believe, depression. I don't recall anything about with anxiety. In particular. As I know, I do have a list of references if anybody wants them to look up these papers, or for these papers that we were talking about. Yes, sir.
You had discussed sleep efficiency and cognitive decline as a person ages, and in these studies, was that did they control for physical activity? Because physical activity can have a significant impact on both sleep and cognitive decline.
Absolutely. That's a really excellent point. For these studies, we're controlling for medical history, and in part, some of them did control for a sedentary lifestyle as a risk factor, but I can't say that really all. The one talking about 2,000 plus men, I believe, specifically control for look at sedentary lifestyle. But I'm not certain of the others. But it's, I think, a really good point as well, because that's certainly going to put people at high risk.
Thank you.
Thank you.
So talking about sleep and neurodegeneration, one thing that came up for me in thinking about that was the association of BDNF with slow wave activity. And I wondered if any of the literature that you looked at in terms of mediating factors discussed BDNF, or possibly also, alternatively, the increase in pro-inflammatory cytokine release associated with slow wave activity.
Certainly. Did not see anything in specifically with the papers that we were talking about, or in my sort of outside review of those as well, looking particularly at any of these either inflammatory cytokines or other neurotropic factors. But I think it certainly kind of brings out a really good point that there's likely a lot of interplay between those two. But in general, none of the papers specifically mentioned anything about that.
Great presentation. Thank you again, Dr. Gilley.